Now I'm going to allow you to ask some questions of Dr. Crashy and Dr. Raman, and they'll be able to respond to any specific questions that you may have.
When I look at the numbers here, 89,000 patients, 4 doctors, 4 rheumatologists. So you're all saying, among all of you, more than 20,000 patients. That's not just the population. That's someone's got to see them at some point. So you would be seeing that many patients? At least on a,
No.
It may not be a regular basis, but someone would have had to see them.
The answer is we don't see that number. But as Dr. Hamilton and Dr. Lewis said, there are 2 points here. One, unfortunately, many of these patients end up not seen, and they end up having to have surgery or totally disabled or even worse. So that's a price for this. The second one, and you raised an important point, the average rheumatologist in Canada takes care of about 500 patients of rheumatoid arthritis, these more serious patients with the more serious debilitating disease. The average rheumatologist in Newfoundland, and I talk about myself here, and I'm sure my colleagues are in the same area, we take care of more than 1,000 of these patients. So this is by itself. So immediately we're taking double the number. These patients, as Dr. Hamilton alluded to, need so much care. And realistically, there are patients, we try our best, that's the simple answer, and of course you know that. But more importantly, there are lots of these patients, one, that needs to be seen are not seen. We don't know why. There are many reasons why. We can discuss it in a different session, and I think our colleagues already alluded this when they talked about the family medicine and internal medicine specialist. 2, the patients we are seeing, and Dr. Hamilton said, needs to be seen regularly 3 to 6 months. Many of these patients, unfortunately, are not seeing at that regular interval that they needed to be seen. So there is a price that, unfortunately, our patients are paying, not to mention that the strains and the stresses that is put in the healthcare system in general.
I believe this issue came up a while ago in the media because one of the 5 rheumatologists that there were at the time left. If I could get you to comment on what the effect of losing one rheumatologist has had in the past few months on the care you're able to give your patients, essentially, and the amount of time your patients have to wait to see one of you.
Well, I guess if you do the math, if one is gone, then the other 4 have to take up the slack. So we already have taken 1,000 patients off our list as of January. And the idea to do that was because we're hoping to see the more, we'll say, urgent or semi-urgent patients quickly. But now that we've lost one, okay, we're sort of set back again, so that makes puts just an added strain, and that's going to increase length times further and further. So right now, there's no way we can provide what we call good service to our for all patients, because we just don't have the numbers. And the only way that we can hopefully improve service is to increase our numbers. And the way to do that is to attract more rheumatologists to our province. Now, it's interesting. In the next couple of years in Canada, there will be approximately, I think 53. I think is that right? 53 right. New rheumatologists available for the country. They will be finished their training. The Rheumatology Association across the country has put a push in the past several years to increase the trainees because we need more rheumatologists. But the thing is, we won't be able to attract these people to our province if we're not competitive, and that's a different issue. But that's an important issue. So that there is opportunity out there to recruit more. But the thing is, we have to make it such that the environment we work in here is competitive enough to attract more these graduate rheumatologists to our province.
Do you know how long it's been since you had a new one? Just to follow on that point.
Beg your pardon?
Sorry. Do you know how long it's been since you've been able to recruit a new
Well, the last new one came in 2000. I think it was 2006. I would think that was, and that's Dr. Seti, who's actually leaving this year, right? So it's 2006. Yeah. And the one before that was 2005, and I came in '87. So it's many years ago.
Those 1,000 people, unless you get a new rheumatologists they would be seeing, or what's the
Well,
status?
well, the status is this, is that they've been what we call temporarily removed from our list. But until we get the waiting times for those patients that are considered to be urgent and semi-urgent to a reasonable level, then those patients will temporarily remain off that list. And that could be, unfortunately, if you look at anybody, it'll be for years and years and years, which is a lot, which doesn't make any sense, but that's the way it is, unfortunately.
What time, like, the most urgent patients are being seen, so can you give me an idea of, if you're dropped off the waiting list, I mean, what kind of conditions are these people in?
Well, what we've done, in order to do that, we obviously, we notify those patients, obviously, we send letters directly to them. And also, we've written to their family doctors as well, and we've given them some resources that they can avail that hopefully will help them to manage these patients in the interim, but that's not ideal. That's the way it's worked out.
I'll make a comment here. One, we said earlier that Dr. City is leaving, and most of his patients are the sicker patients, the rheumatoid arthritis, the lupus, the psoriatic arthritis patients. So one of the urgent things that the four of us, with our fourth colleague who's not here today, is to take care of these patients. And that's, I assume, that we've done. I took a fair bit of them. I'm working outside the Eastern Health, but my colleagues in Eastern Health did the same thing. So that's part of the reason why we have to deal with. These are patients who are already taking serious drugs, who are already having a diagnosis of serious diseases. That's one point I want to raise, is that these are also suddenly a huge influx of sick patients that has to be taken care of today, not tomorrow. Unfortunately, that we have lived with the problems of the thousands who are either really not even in the system or in the system and hasn't been dealt with. And simply, we have to prioritize. It's not an ideal world, as Dr. Hamilton said, but that's the point. And it is the worst thing that you can do when you think, as Dr. Lewis mentioned, how these patients are suffering. And you have to say, oh, I think this patient needs to be seen tomorrow, and the other one needs to be seen a year ago. It's not ideal, and there must be a better solution.
But I think your point is right in the sense that it's heartbreaking to leave 1,000 patients. The reason why we have to do it is that, given our specialty, there are certain medications that we use that really only rheumatologists can use, and it's not really fair to the family doctors to help look after those patients if they don't know enough of those medications. And so we've given back to the family doctors the patients that they can potentially look after, but they really do need to be seen by us because they're actually asking us to see them. So it's far from ideal in terms of how it's being managed, but we had to set priorities, and the priority initially was to look at inflammatory arthritis. In other words, those people, they're going to damage quicker, and damage, as you realize, will lead to disability. Disability will lead to time off work, and so it's just a vicious circle. So we just had to make really tough choices in who to see first. But none of us are really happy with what we had to do. It's just kind of survival mode at the present time.
And this all happened before you lost the rheumatologist?
Yes,
Exactly.
that's correct.
Yeah.
That's correct. That's correct.
So now, are there more drastic choices then to be made?
Obviously, like I said already, when you got five gone down to four, then there's the times that we were hoping to decrease waiting times for the urgent and semi-urgent patients, but that's not going to happen in any short time either. There's just too many referrals. Like I said, there's right now at Eastern Health, I know about Dr. Croatia, but at Eastern Health there's 600 that are labeled as what we call priority 1, priority 2, which are urgent, semi-urgent with inflammatory joint disease that are waiting to be seen.